The ARCADIA trial was a randomized clinical trial funded by the NINDS of the NIH, looking at patients with recent embolic stroke of undetermined source, which is also called ESUS. And amongst the ESUS patients with recent stroke, we then did a number of tests to find a marker of atrial cardiopathy. And if you had the recent ESUS and a marker of atrial cardiopathy, then you could be randomized to either aspirin or apixaban for secondary prevention of future stroke events. And I'll just add one brief comment on atrial cardiopathy. There have been a couple of other large ESUS trials randomizing patients to anticoagulation versus aspirin, but not selecting patients with a more likely cardioembolic cause. And those trials have not shown a benefit of anticoagulation over antiplatelet therapy or aspirin. And so what was, I think, next generation about ARCADIA is that we were focusing on patients with these atrial cardiopathy markers, thus more likely having a cardioembolic cause for their stroke, and thus we thought more likely to benefit from anticoagulation over antiplatelet therapy. Now, it was a lovely theory, and as people have quoted others, slain by ugly facts. And we did report the main results of the trial in May of 2023 at the European Stroke Organization conference. And in fact, after over just 1,000 or so patients were randomized, the Data Safety Board recommended that we terminate the trial for futility, as there was literally zero difference. The hazard ratio was 1.0 between the two arms that were randomized to either apixaban or aspirin. So the study was stopped early for futility, not showing any benefit. One of the questions that arose when we saw these negative results in the main trial was whether or not we had chosen a subgroup of the ESUS patients that had severe enough atrial cardiopathy to benefit from the anticoagulation. So the results that I presented on behalf of the ARCADIA investigators at the World Stroke Congress were focusing on whether the effect of apixaban over aspirin varied depending on the severity of your atrial cardiopathy. And we analyzed the data in a number of different ways for each of our three biomarkers. And our three biomarkers were the NT-proBNP in the serum, the P-wave terminal force in lead V1 from a standard ECG, and the left atrial diameter index from an echocardiogram. For each of those three primary biomarkers, we looked at whether apixaban started to show a benefit over aspirin as we got to the more severe levels of the markers. And we were unable to show any such effect there either. So again, the results were quite neutral. And then we also devised two separate atrial cardiopathy severity scores where we used the combination of the three biomarkers to create a score of atrial cardiopathy severity and did similar analyses. And again, unfortunately, we were unable to find any relationship whereby as atrial cardiopathy severity increased, there was suddenly evidence or even a signal of a benefit of apixaban over aspirin. I will add one caveat, which is that because the study was stopped early, that reduced the number of outcome events that we had and thus reduced the power we had to find any significant findings, even in the main study, let alone in these additional secondary analyses. I think that these results compared with other studies, and there are still a couple of ongoing studies looking at subgroups of ESUS trying to show a benefit of anticoagulation over antiplatelet therapy. But really, with the information that we have so far, and even if, atrial cardiopathy is a real thing, there certainly are real pathologic changes that precede atrial fibrillation. But through, I think, excellent research, we've now not been able to show that there's a therapeutic implication of the presence of atrial cardiopathy. They still seem to benefit just as well for stroke prevention from aspirin compared to an anticoagulant. And so for now, I think the standard of care for antithrombotic therapy for secondary stroke prevention in patients with recent ESUS is still antiplatelet therapy. So the only other thing that I would like to do is, on behalf of the ARCADIA leadership team, extend our deep thanks to a large number of people who helped make the trial possible and brought us to completion, including funding from the NIH, from BMS Pfizer, and from Roche, from a huge group of collaborators, including our key study coordinators, Rebecca Aragon Garcia and Pam Plummer, and especially to our local coordinators. And then finally, none of this would have been possible without the patients and their families who are willing to participate in this research. We are greatly indebted to them all.